Now we are going to discuss glucose reabsorption in different parts of nephron. So this is a continuation of the tubular transport part 2, right? So proximal tubules absorb 100% of the glucose, means all glucose will be absorbed within proximal tubules only. Proximal tubule means it has two distinct parts, that is the proximal convoluted tubules and the proximal straight tubules. Proximal convoluted tubules, it absorb 90% of the total filtered glucose from lumen. So suppose this is your luminal side, right? Okay. So from the luminal side, 90% of the glucose will be reabsorbed into the blood by the proximal convoluted tubules, and remaining 10% of the glucose will be reabsorbed from proximal straight tubule, right? So this proximal straight tubule is for 10%. Don't forget this. It has been asked multiple times in INI set type of examination, NEET PG examination, so very important. Now the transporter protein, which is responsible for glucose reabsorption from proximal convoluted tubules, it reabsorbs one molecule of sodium and one molecule of glucose from lumen to cell, and the transporter is known as SGLT type 2 variety. So I should write down type 2 like this. So this is SGLT type 2 variety. The transporter which reabsorbs 10% of the total glucose at the level of proximal straight tubule, it is also SGLT. It absorbs 2 molecule of sodium with 1 molecule of glucose, right? And this is SGLT type 1. So very important. SGLT type 2, it is reabsorbing 1 glucose, 1 sodium. SGLT type 1, it is reabsorbing 2 molecule of sodium with 1 molecule of glucose, right? So SGLT type 2 is 90% glucose reabsorption and type 1 is only 10% of the total glucose reabsorption. This SGLT type 1 is also present in the intestinal epithelium for the glucose transport there in the gut, right? We all know that. Now, by this transporter, the glucose is entering from this lumen up to the level of cell cytoplasm. So you require another transporter with which the glucose will absorb from cell cytoplasm to your blood. So the glucose is absorbed from the basolateral surface by another transporter. If it is SGLT2, then the transporter on basolateral membrane will be GLUT2, right? And if it is SGLT1, then the basolateral transporter will be GLUT1. So the transporter here is GLUT1. With the help of this, the glucose will be reabsorbed in the blood. So very simple. I have to remember SGLT type 2 is the main transporter absorbing 90%, which is coupled with GLUT2, right? And SGLT type 1, 10% glucose reabsorption coupled with GLUT1. So SGLT type 1 or type 2, they are the secondary active transporter, and this GLUT1 or GLUT2, they are the facilitated diffusion transporter. Okay, this much all you have to remember about glucose absorption at the level of proximal tubule. Now this SGLT type 2, this transporter is inhibited by certain groups of drug. So if you inhibit this, what will happen? The filtered glucose will not be able to absorb at the level of proximal tubule, so glucose will be excreted in the urine and your blood glucose will be decreased a little bit. That's why the drugs which inhibit this SGLT2 is used as an anti-diabetic medicine, and they are, all of you know, DAPA, CANA, gliflozin group of drug. Gliflozin group of drug, DAPA gliflozin, CANA gliflozin. So these are the drugs which inhibit only and only SGLT type 2. They are not the inhibitor of SGLT1. Okay, so they are used for diabetes mellitus treatment. Okay, now apart from this, we have to understand a little bit more about glucose absorption, some more concept. Okay, that is the transport maximum of glucose. Okay, transport maximum of glucose. So let's see how to understand this topic. So suppose one patient who has a blood glucose of 200 milligram per dl. So I am drawing a schematic diagram to understand this. Okay, so suppose this is the glomerular capillary. Okay, and in this patient the glomerular capillary contain how much glucose? 200 milligram per dl, right? And I'm taking another patient for parallel discussion. So in this patient the blood glucose level is little more higher. Okay, so here the blood glucose suppose 300 milligram per dl, more higher, diabetic. Okay, so this huge amount of glucose is reaching at the level of glomerular capillary. Okay, so there will be filtration. Okay, so I'm drawing the Bowman's capsule. Okay, Bowman's capsule and proximal convoluted table in both the cases. Bowman's capsule and proximal convoluted tables. Suppose in both the patient the GFR, that is the glomerular filtration rate is 125 ml per minute normal. Suppose calculate how much amount of glucose will be filtrate in the first patient in 1 minute and in the second patient in 1 minute. How much amount of glucose will be filtrate? Okay, this calculation, what we are going to do is calculation of the filtered load of glucose. So what I'm saying, we have to calculate what is the, that is the meaning. So here the blood glucose is given in 200 milligram per dl. Dl means it is 100 ml. So if I express into ml, so 200 milligram glucose is there in 100 ml plasma. That means 2 milligram glucose is present in 1 ml of plasma. And in this patient, how much plasma is filtered in 1 minute? 125, because that is the GFR. So 125 ml of plasma is filtered in 1 minute. So how much will be the tubular load in this? Okay, filter load or tubular load in this patient. So in the first cases it will be 250 milligram per minute. I hope you are getting it right. So simply GFR is 125 ml and plasma glucose is 2 milligram per ml, right? So if you just multiply this, what you are going to get? You are going to get 250 milligram per minute. This is known as a filtered load or tubular load of glucose, right? So in the second patient, same thing I am going to do. Here the plasma glucose is 3 milligram per ml, right? And the GFR in 1 minute there is 125 ml plasma is getting filtered. So 1 ml plasma contains 3 milligram glucose. If there is 125 ml of filtered, so how much total glucose? 375 milligram of glucose is going to reach at the level of Bowman's capsule in 1 minute. So 250 milligram in 1 minute filtration is the tubular load in the first patient. 375 is the tubular load in the second patient or filtered load. Now, by concept, we know that in both the cases, glucose will be reabsorbed by transporter protein or carrier protein, and they are nothing but SGLT type 2, 90%, and SGLT type 1. So, we are trying to understand the second one. Second concept is that now this glucose will be reabsorbed here. So, glucose reabsorption is going on. Okay, here also glucose reabsorption is going on. Now this glucose reabsorption is done by a carrier protein or transporter protein which has a property of saturation. What do you mean by that? Means if the glucose amount which is reaching at the level of this Bowman's capsule is very high, then all the carrier protein, all the transporter protein, SGLT2 or SGLT1, they will be flooded, they will be saturated with glucose. So whenever there is saturation, after that saturation point, no further glucose absorption increment can be possible, right? Right. So that is saturation. So if by some measure I can measure that how much is the maximum amount of glucose that can be reabsorbed by this proximal tubule, that value is known as transport maximum of glucose. What I am saying, Tm, T max of glucose, T max of glucose, what is that? So it is the transport maximum. This is known as transport maximum of glucose or maybe any substances, but for glucose we are understanding glucose here. So transport maximum of glucose is 375 milligram per minute in respect to tubular load. Okay, getting my point. So what is the value of transport maximum of glucose in a normal subject? 375 milligram per minute, means 1 minute if there is filtration of 375 milligram of glucose, all the glucose will be reabsorbed. That is the meaning of transport maximum. So what is transport maximum? It is the maximum amount of glucose that can be reabsorbed by proximal tubule, is known as transport maximum of glucose. How much is that? Is 375 milligram per minute with respect to this tubular load. So 375 milligram per minute means what is the blood level of that glucose? Blood level of that glucose is 3 milligram per dl. So with respect to plasma level of glucose, this is 3 milligram per dl with respect to plasma level, and this 375 milligram per minute, this with respect to tubular load. Getting my point? This much of tubular load will be done by how much of plasma glucose? 300 milligram of plasma glucose, 300 milligram per dl. Getting my point? So transport maximum is 375 milligram per minute or 300 milligram per dl in respect to plasma glucose. So if we assume that the transport maximum is 375 milligram per minute, in the first patient, how much glucose is reaching in 1 minute? Only 250. And you can absorb how much maximum? You can absorb up to 375 milligram per minute. So do you think any glucose will remain to be excreted in the urine in this patient? Answer is no. So urine will be zero glucose here. And in the second cases, again the maximum is 375 and here the filtered load is also 375. So all will be reabsorbed even in the second patient also. So do you think there will be any glucose at the level of urine? Answer is zero glucose at the level of urine. But this is not matching with the clinical scenario, because we all know that in clinical scenario the second patient is a flank diabetic and the first patient is also diabetic. So in both the cases there will be some glucose in the urine. So if you follow this transport maximum concept, the transport maximum means maximum amount of glucose that can be reabsorbed by the proximal tubule is 375 milligram per minute, then it is not matching with the clinical scenario. That's why there is a second value, there is a second concept that is known as renal threshold of glucose. That is known as renal threshold of glucose. So this renal threshold is the actual scenario. Okay, renal threshold concept is similar to the transport maximum concept, but transport maximum concept is a theoretical value. Okay, experimentally it has been proven that maximum amount of transport or absorption of glucose capacity in nephron is 375 milligram in 1 minute. But the actual value or the real value is renal threshold. And what is that? Renal threshold is 200 milligram per dl of glucose in respect to what? Whenever you are saying 200 milligram per dl, this is the plasma glucose, and if you express in respect to tubular load, so 200 milligram of plasma glucose means what will be the tubular load? 250. So if you express in terms of tubular load, this is 250 milligram per minute in case of load. Getting my point? So renal threshold concept is saying that actual transport capacity of proximal tubules is how much? 250 milligram in 1 minute, not more than that. So now you think here. So if you assume, okay, that the maximum capacity of transport from this proximal tubule is 250 milligram per minute or 200 milligram per dl, then in the first cases it is just 250, means very little amount of glucose may start appearing in urine in these cases. So it is matching with the clinical scenario. 250, just it will absorb, maybe few glucose will be excreted in the urine. Okay, in the second cases we are assuming that the renal threshold is 250 milligram per minute or 200 milligram per dl. How much is the tubular load here? 375 milligrams. So how much glucose is going to appear in the urine? 125 milligram per minute glucose is going to appear in the urine. So obviously glucose will be positive in the second cases. So basically, if you consider renal threshold value, then that is matching with the actual clinical scenario rather than transport maximum value. So why there is a difference? Transport maximum value, I am saying that the TM value is 375 milligram per minute. This is the ideal one, ideal concept. And then I am saying renal threshold is 250 milligram per minute. This is the actual. Okay, actual means this Tmax is basically a theoretical concept. This is a kind of theoretical concept, and this is more practical concept. So why there is a difference between these two? Okay, the scientist who has calculated this Tmax, okay, obviously there's some reason is there. Okay, so why there is a difference between these two? Now, no doubt. Tmax value is calculated based on one assumption, based on one experiment, okay, that all the nephron in your kidney are 100% functioning and all of them are equal functioning. Very big assumption too. Okay, one assumption is that 1 million nephron in your kidney, all of them are equal functioning, and all of them are functioning at their peak level, 100% functioning. Do you think this is possible clinically? Answer is no, 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 right? So that's why if all your nephrons are 100% functioning and all of them are properly functioning, okay, equally functioning, then what is with the maximum capacity? What will be the maximum absorptive capacity of glucose from proximal convoluted tubules? That is 375 milligram per minute. But actually, some of the nephrons are not properly functioning and some of the nephrons are not 100% not functioning with that of the other one. So that way, the actual renal threshold value is only 250 milligram. So there is a difference between actual ideal value, okay, and actual value, okay. So ideal one and real one, actual one, there is a difference between these two. This difference is known as the splaying effect of kidney. This is known as SPLAY, splay effect of glucose reabsorption. Getting my point? So the difference between theoretical value and practical value, the difference between the ideal one and actual one is the splay. Okay, so this splay sometimes explained with the help of a graphical representation, which can be given as an image-based question. So you have to understand that. So your x-axis is plasma glucose, x-axis is plasma glucose concentration. So whenever plasma glucose is increasing, what will happen to filtration load of glucose? Obviously increase. So I am drawing one filtration load. Okay. So more the plasma glucose, more will be the filtration load of glucose. So this yellow color curve, this indicate filtered load or tubular load. So more the filtration, the proximal tubule will try to absorb more glucose up to a certain limit, up to the saturation of SGLT. So now if I draw the reabsorption curve, it will go same to same with the filtration, same to same with the filtration up to a certain point. After that, there will be plateau, means no further absorption is possible. So there is a limitation of absorption. Okay, so this is absorption curve, okay. The value, okay, the maximum absorption, what is the name of that? This is nothing but your T max value, okay. So after this T max value, no further absorption, increment of absorption is possible. So this absorption, whenever I am saying T max, this is the absorption curve, ideal curve or actual curve. So this is the ideal, okay, ideal absorption curve of glucose, okay. But that does not happen because this ideal curve is plotted based on the assumption that all of your nephrons are equally functioning, all of your nephrons are 100% functioning. So now if you draw the actual curve, okay, actual curve of glucose reabsorption, I am drawing with this green color. So initially the reabsorption will be proportionate to filtration, filtration, filtration. Now from this point onward, the reabsorption curve will be diverted from the actual curve. So from this point onward, the reabsorption curve is diverting from the actual one. So now I can understand that there is a deviation of this actual absorption curve. So this is also absorption curve, but this is the actual absorption curve. Okay, and this point from where it is deviating, this is nothing but your renal threshold point. So after this renal threshold point, there is deviation of this curve. The gap between these two, this gap between these two, this zone is nothing but known as the splay. This is nothing but splaying effect of kidney. Okay, splaying effect of glucose absorption. So if I ask you, urine glucose will start appearing from which point? From after this point. If your glucose level is beyond this renal threshold point, the glucose will start appearing in the urine. So if I draw a curve like this is urine glucose curve. This is urine glucose curve, right? More and more plasma glucose after this point, more and more glucose will appear in the urine. So this way you have to remember the splay effect and the actual and ideal curve. So this is all about glucose absorption that you have to remember. Now coming to the next one, that is the water reabsorption. Okay, so water reabsorption in different parts of nephron. Some part of the water reabsorption related discussion we have already done in the sodium reabsorption chapter. So here we are going to summarize everything. So water reabsorption, okay, it generally happens at the level of proximal tubule, 65% of total water reabsorption, right? At the level of DTS, that is the descending thin segment, another 15% water reabsorption occurs. Okay. Now the water reabsorption which occurs at the level of proximal tubule or descending thin segment of the loop of Henle. Okay. This water reabsorption occurs by which aquaporin? So suppose this is the epithelium cell of the proximal or descending thin segment of loop of Henle. If you think of the luminal transporter or you think of the basolateral transporter, in both the cases, the aquaporin which is present for water reabsorption here is aquaporin 1, aquaporin 1. In both the cases, aquaporin 1 is present on the luminal membrane also, aquaporin 1 is also present in the basolateral membrane also, right? So this water reabsorption which is happening at the level of proximal tubule and the descending thin segment of the loop of Henle, do you think ADH can stimulate this water reabsorption? Answer is no, because ADH has action only on aquaporin type 2. Okay, only on aquaporin type 2. So this water reabsorption here is ADH independent. Okay, whether your ADH is there or not, ADH present or absent, water reabsorption in the proximal tubule and distal thin segment of loop of Henle will continue in the same manner. This kind of water reabsorption is known as obligatory. Okay, obligatory water reabsorption. Okay, obligatory water reabsorption. Getting my point? So now the remaining portion of the water will be delivered in the distal tubule, because we know TAL, there is no water reabsorption, that is impermeable to water, that is the diluting segment. So at the level of DCT and at the level of collecting duct, now the water reabsorption here is based on ADH. I told you at the beginning of the tubular transport chapter also. So here, if the ADH is present and if the ADH is not present, so ADH is positive, how much water will be reabsorbed in the DCT and collecting duct? 10% plus 4.7%, means almost 15% water is reabsorbed from the DCT and collecting duct if the ADH is there. But if the ADH is absent, then what will happen? Only and only 2% water will be reabsorbed in the DCT and collecting duct. So getting my point, 15% and here it is 2%. Means in absence of ADH, the distal tubule as well as the collecting duct is almost impermeable to water. Okay, huge amount of water loss will be there if the ADH is not there. But if the ADH is there, it will increase the water reabsorption at the level of DCT also, at the level of collecting duct also. But even after increment, how much maximum water can be reabsorbed in presence of ADH? That is a 15%. Total amount of water reabsorption from this distal tubule and collecting duct is 15%. And if it is ADH is not there, only 2%. This kind of water reabsorption which is dependent on ADH. Okay, so this is obviously the ADH dependent water reabsorption. This is known as facultative water reabsorption. Facultative water reabsorption. Okay. Now if I ask you how this ADH is increasing the water reabsorption in the collecting duct and DCT, we have already seen this phenomena, we have already seen this mechanism, that if it is a cell of collecting duct and DCT, okay, if it is a cell of collecting duct and DCT, the transport of the aquaporin which is present on this luminal surface is aquaporin type 2, and this is the aquaporin which enhances water reabsorption from lumen to the cell cytoplasm, and from the cell cytoplasm aquaporin 3 and 4 will reabsorb the water. So this is aquaporin 3 and 4. ADH is going to stimulate which aquaporin? Only and only aquaporin 2. So ADH will work from this basolateral membrane. It will act on this V2 receptor. That V2 receptor will increase this CAMP. CMP will stimulate this aquaporin 2. Actually, it is not stimulation. I have already discussed that CMP bring the vesicles from the cytoplasm to the membrane, and those vesicles contain the aquaporin 2 channels. So basically CMP will input aquaporin 2 channel on the luminal membrane and more water will be reabsorbed. So this way you have to remember about water reabsorption. Okay, and the last reabsorption that you have to read is the potassium. Okay, so potassium, it is the only electrolyte which is reabsorbed as well as secreted. So it is the only electrolyte I am talking about, which is reabsorbed as well as secreted in different parts of nephron. Okay. Now, whether the potassium will be secreted or reabsorbed, it depends on your blood level, because you know potassium is a very important electrolyte in your blood. Okay, so body will not want to lose extra potassium from your body, and body will also not want to gain extra potassium in blood, right? So when your potassium level is very high or low, how the different parts of nephron is going to handle the potassium, that you have to remember a little bit. So a person in a low potassium state condition, low potassium state, okay, so the potassium level in the blood is very low. Okay, potassium in the diet is very low. Suppose low potassium state or low potassium in diet. In these cases, secretion of potassium is not going to happen, or if it has happened, that's very negligible. So all part of the nephron in these cases will try to reabsorb potassium. So PCT will reabsorb 80% of potassium. Then TAL, okay, TAL will reabsorb another 10% of potassium. Then DCT, that is the later part of the DCT, particularly the DCT and cortical collecting duct, they also reabsorb little bit of potassium, 2%, and medullary collecting duct, important, it can also reabsorb another 6% of potassium. So all of this segment is causing reabsorption of potassium because it's a low potassium state in the body. So how much potassium you have reabsorbed? Almost 98% potassium is reabsorbed. So urine will get only 2%. Urinary excretion of potassium is only 2%. But if you look at a condition when the person is having high potassium in blood, so high potassium state, okay, or high potassium in diet, what will happen in this cases, body will try to get rid of potassium, okay, so potassium will be secreted, okay, potassium will be secreted. So which portion is going to, which part of nephron is going to secrete potassium? Look at, so PCT, okay, it will reabsorb potassium, how much percentage? 80%. TAL, it will reabsorb potassium, how much percentage? 10%. So this two is the reabsorption. Now potassium secretion will be seen at the level of DCT. Which part of the DCT? The later part of the DCT. Potassium secretion occurs in the later part of the DCT and the beginning part of the collecting duct, cortical collecting duct. So the later part of the DCT is known as the connecting tubules. I am writing here DCT, particularly the connecting tubules and the cortical collecting duct. They are going to secrete potassium because the potassium level is very high in the blood. How much percentage of secretion is possible? 20% to 180%. Oh my god, getting my point? Suppose the filtration amount of potassium we are taking at 100%. So whatever filtration of potassium is occurring in a patient of high potassium state, high potassium diet, secretory potassium may be more than that also. That is 20 to 180%. So secretion can increase to a very high level. And which part of the nephron is going to secrete potassium? That is the DCT and cortical collecting duct, the later part of the DCT. After this secretion, the medullary collecting duct can again reabsorb a little bit of potassium in these cases, and that is 20 to 40% potassium can be reabsorbed at the level of medullary collecting duct. So this is reabsorption also, okay, and this is also reabsorption. But in between this white color, what I have written here, this is secretion of potassium, very important for MCQ. Which part of the nephron secrete potassium? So after this, the urine is going to excrete huge amount of potassium that can ranges from 10 to 150%. So huge amount of potassium is excreted at the level of urine. So suppose one person is excreting 150% of potassium in the urine. So what is the source of this potassium? It is from filtration or it is from secretion? It is from secretion. Getting my point? Because filtration, suppose it is 100%, 80% is already absorbed at the level of PCT, 10% is already absorbed at the level of TAL. So if a urine is getting potassium which is more than this 10%, okay, 90% is reabsorbed here. If it is more than 10%, then what is the source of that potassium? It is coming from the process of secretion. Why I am saying so? Because this has been asked in a MCQ in AIIMS PG entrance examination, that a person is taking potassium containing salt hugely in his diet. The source of urinary potassium in this patient is mainly from the process of secretion. So this way you have to remember that potassium is the only electrolyte which can be reabsorbed as well as secreted in nephron, and the portion where it is getting secreted, okay, is later part of the DCT and cortical collecting duct. The same part can also reabsorb, but look at the medullary collecting duct. Medullary collecting duct is only and only reabsorbing the potassium, it cannot secrete. So there is a specific portion of the nephron which is secreting potassium, and that's why it is an MCQ. So this is all about your tubular transports of various substances. We are going to discuss acid secretion in a separate chapter.